This is the fourth and final video in this series on obstructive lung disease, and the topic will be acute exacerbations of asthma and the COPD. After watching the video, you'll be able to recognize an acute exacerbation based upon symptoms, exam findings, and changes in peak expiratory flow, be able to demonstrate proper use of a peak flow meter, determine whether a patient with an acute exacerbation should be treated as an outpatient or inpatient, and last, choose an appropriate initial treatment regimen based upon exacerbation severity. So first, what is an exacerbation? An exacerbation is a worsening in symptoms and objective findings that is beyond the normal day-to-day fluctuation of baseline lung function. Identifying exacerbations quickly is critical. Early recognition and treatment can prevent it from becoming life-threatening. People with asthma and COPD get exacerbations for all kinds of reasons. In asthma, common triggers include allergen exposure, viral upper respiratory tract infections, air pollution, exercise, cold temperature, and bacterial pneumonia. In COPD, the most notable triggers are infections, that is, pneumonia and URIs. Air pollution can play a role as well, and somewhat unexpectedly, pulmonary emboli may also be triggers, as I'll discuss at the very end of this video. Of course, many exacerbations of both asthma and COPD are either from medical non-adherence or are idiopathic, that is, a specific cause can't be identified. The symptoms of asthma and COPD exacerbations are very similar to one another. An asthma exacerbation is associated with a subjective increase in baseline cough, shortness of breath, or wheezing. Some patients also experience chest tightness or decreased exercise tolerance. A COPD exacerbation is typically defined by a subjective increase in baseline cough, shortness of breath, or sputum purulence. In the last video on stable disease, I mentioned that the physical exam in asthmatics who are in between attacks may be completely normal. Well, during an attack, that's not the case. Depending upon the severity, one can see tachycardia, tachypnea, and hypoxemia. One can hear wheezing and decreased breath sounds. One can observe use of accessory muscles to breathe, such as the sternocleidomastoid and scalene muscles in the neck. Nostrils may be flaring, and the patient might speak in short sentences. Sometimes patients adopt the so-called tripod position, shown here, where they sit leaning forward, resting their hands on their knees. There's a theory that this somehow improves lung mechanics, though to the best of my knowledge, this remains to be proven. And when the exacerbation is particularly severe, as in life-threatening, patients can exhibit cyanosis or altered mental status. The physical findings in a COPD exacerbation, they are completely identical. In addition to the physical exam, another important objective measure of exacerbations, specifically asthma exacerbations, is peak expiratory flow, usually shortened to just peak flow. Reductions in peak flow are caused by increases in airway resistance. Peak flows can be measured relatively accurately with an inexpensive, handheld device particularly called a peak flow meter. Here's what a peak flow meter looks like. It's a very simple device. Primary care clinics and hospitals should all have these easily available. This particular one was picked up off of Amazon.com. To use it properly, the gauge should be set to 0, and the patient should be sitting straight or standing, and they should inhale as deeply as possible, make a tight seal with their lips around the mouthpiece, holding the tongue down, and then exhale as forcefully as possible. The number on the gauge indicates the maximum airflow the patient achieved during expiration. To estimate severity of airway obstruction, the test should be repeated at least 3 times, and the highest value used for decisions about treatment and triage. In patients with asthma, their peak flows are variable, sometimes totally normal and sometimes not. The normal range for peak expiratory flow is dependent upon age, gender, and height. Every patient with asthma should establish a personal baseline measure when they are feeling at their best. Then during exacerbations, the severity can be determined partially by how their peak flow at that time compares to this baseline. Some peak flow meters will have additional indicators to help with these comparisons. For example, on this meter, the green-yellow marker can be set at 80% baseline, and the yellow-red marker can be set at 50% baseline. If the peak flow is within the green zone, the person's asthma is under good control and they should continue their current treatment. If it's within the yellow zone here, this may indicate a mild exacerbation requiring the adoption of a specific home treatment plan that had been discussed ahead of time with their doctor. If it's within the red zone, that may indicate a severe exacerbation requiring immediate medical attention. So we've covered the symptoms and objective findings of asthma and COPD exacerbations. Now let's discuss treatment. Although it may not be the very first decision to make, one of the most fundamental early decisions is whether to treat the patient as an outpatient or inpatient. I started to create separate lists for the indications to hospitalize in either condition using published guidelines, but as I did so, I realized that they are essentially the same. They are inadequate response to prior attempt at outpatient management, a failure to improve in the ED or urgent care clinic, the presence of severe symptoms that prevent self-care, a subjectively marked increase in dyspnea over baseline, altered mental status which strongly suggests major gas exchange abnormalities such as hypoxemia or acute respiratory acidosis, a lack of home support, for example if the patient lives by themselves, an uncertain diagnosis, for example if the physician thinks that a COPD exacerbation is most likely, but they haven't fully ruled out other diagnoses such as CHF or a PE. And finally, high-risk comorbidities, which are essentially CHF, chronic kidney disease, diabetes, cirrhosis, or concurrent pneumonia. The presence of any one of these would make me strongly consider inpatient admission for either an asthma or COPD exacerbation, even if the exacerbation itself seemed otherwise relatively mild. At this point, I'm going to run through the list of treatments available for asthma and COPD exacerbations, along with indications for each. Please note that this is a general summary and is not meant to guide the treatment of any one specific patient. The approach to treating exacerbations, particularly asthma exacerbations, is very nuanced, and this chart should not be used by patients as a substitute for medical advice from their doctor. In asthma, the most fundamental of treatments for exacerbations is the short-acting bronchodilator. For mild to moderate exacerbations, this usually means just albuterol, whereas for severe exacerbations, a combination of both albuterol and ipratropium is used. For the duration of treatment, I have here indefinitely because short-acting bronchodilators should be used on a chronic, as-needed basis for all patients. Although I have never personally encountered this, apparently epinephrine inhalers are available over the counter in some countries, in which they may be marketed towards asthmatics. These drugs are associated with significant cardiac side effects and have uncertain safety. Asthma experts recommend against their use. A question that frequently comes up about the conventional inhaled bronchodilators, like albuterol and ipratropium, is whether it is best to give them via a metered-dose inhaler, or MDI, or via a device called a nebulizer. Here on the left, we see a woman using an inhaler, and on the right is a woman using one of several nebulizer setups. With the nebulizer actively in use at the time of the photograph, a fine mist would be coming out of the end. The question as to which is better was addressed in a 1997 meta-analysis, which looked at 12 trials, all of which were small and some of which were extremely small. The outcome measured was the patient's FEV1 before and after treatment. The meta-analysis found that there was no difference. In response to this paper, I've heard many claim that inhalers are just as good as nebulizers, and since they are cheaper and less labor-intensive on the part of the respiratory therapists in the hospital, we should be defaulting to inhalers for our inpatients. But here's the problem with that. The ability to comply with proper inhaler technique may be compromised by respiratory distress or altered mental status, whereas the response to a nebulizer is neither dependent upon patient technique or even patient cooperation. Therefore, some physicians prefer the use of nebulizers over inhalers, particularly in COPD exacerbations. And don't forget that the quality of that meta-analysis was limited by the extremely small sample size in many of the included studies. Returning to the chart, the next treatment used in asthma exacerbations are systemic steroids, which are used if the peak flow is less than 70% baseline, or if the patient is failing to respond to bronchodilators alone. The choice and dose of steroids is dependent upon the severity of illness. As a general rule, patients not sick enough to warrant ICU-level care are placed on prednisone between 40 and 60 mg daily, and patients bound for the ICU are typically placed on methylprednisolone between 60 and 80 mg IV Q6 to Q12 hours. Note that these doses are for adults. You'll need to consult a reference guide for dose selection in pediatric patients. The typical duration of systemic steroids in asthma is 10 to 14 days, though the patient may stop sooner if symptoms completely resolve. Some doctors prefer using a rapidly tapering dose of steroids, either as part of the 10 to 14 days or tacked on to the end. The next option is IV magnesium, usually reserved for life-threatening exacerbations, and which is given as a one-time dose of 2 grams magnesium sulfate. Once again, this is the dose for adults. Magnesium is speculated to work by inhibiting the influx of calcium ions in airway smooth muscle cells. Antibiotics, which are standard in most COPD exacerbations, as we'll discuss in a minute, are not generally recommended in asthma exacerbations in the absence of concurrent pneumonia. Last, ventilator support, specifically endotracheal intubation, can be performed for life-threatening exacerbations. Non-invasive ventilation, such as BiPAP, is occasionally tried, but its benefit in asthma is not as well studied as it is in COPD, and should only be tried for 1 to 2 hours before the patient is intubated and mechanically ventilated. Some additional therapies which have been used in life-threatening asthma exacerbations include inhaled anesthetics such as halothane, intravenous ketamine, intravenous epinephrine, and inhalation of a helium-oxygen mixture called Heliox. Although occasionally discussed in case reports, no large clinical trial has found any of them to be beneficial, and thus they are not part of conventional treatment protocols, but could be considered in particularly dire situations. Next, I'll run through the same with COPD. You'll see some parallels and also some differences. As with asthma, the most fundamental of treatments are the inhaled bronchodilators. In this case, albuterol and ipratropium are almost always used together. Systemic steroids are also almost always used, or at least they should be. Once again, the dose depends upon the severity of illness. For non-ICU patients, prednisone 30 to 60 mg daily is used. For ICU patients, methylprednisolone 60 to 125 mg IV Q8 to Q24 hours is typical. Typical durations of steroids in COPD exacerbations can range from 5 to 14 days, either with or without a taper. You'll notice that the dose and duration of steroids is similar in asthma and COPD, but not identical. There is not significant scientific evidence behind those differences. This only represents slight variations in the expert opinion and typical practice when treating the two diseases. In my opinion, the most complicated aspect of treating most COPD exacerbations is antibiotics. First, which patients should receive them? Guidelines and expert opinions are not in complete agreement, but for the most part, a patient should probably receive antibiotics if 2 of the 3 cardinal symptoms of COPD are present, that is, increased dyspnea, increased cough, or increased sputum purulence from baseline. Another indication for antibiotics is if the patient requires ventilatory support. What's interesting about antibiotics in COPD is that there is benefit even if a patient does not show clinical evidence of pneumonia. There are a few reasons why this may be the case. First, a COPD exacerbation may be triggered by subclinical or very early pneumonia, which hasn't yet had time to become clinically apparent. There's also evidence that COPD exacerbations may be triggered by acquisition of a new bacterial strain in the airways as compared to the bacterial strains with which the patient is typically colonized. Newly acquired strains are associated with increased inflammation in the upper airways, which could precipitate an exacerbation. One final factor which may contribute to the benefit of antibiotics in the absence of obvious pneumonia is that the markedly abnormal lung architecture of patients with prominent emphysema may preclude the development of the typical radiographic appearance of pneumonia on chest X-ray making the diagnosis less apparent. So what antibiotics are used in treating COPD exacerbations? I'm going to switch over to another chart since antibiotic selection is a bit complicated. It depends on the pathogens which one wants to cover, which is dependent upon the severity of exacerbation and a few other factors. For example, if the exacerbation is mild and there are no risk factors for poor outcome, the primary pathogens to cover are Strep pneumoniae, H. flu, and Moraxella. The first-line treatment is therefore azithromycin, which also has the benefit of covering atypical bacteria whose role in COPD exacerbations is less clear. Second-line treatment or other options would include consideration of no antibiotics, which is advocated by some experts for mild exacerbations. Also, one could consider cefpodoxime or doxycycline. If the exacerbation is moderate in severity, or if there are risk factors for poor outcome, coverage could be a little broader. Risk factors for poor outcome would be things like advanced age, medical comorbidities like CHF or poorly controlled diabetes, or significant abnormalities of gas exchange at presentation. In this case, coverage should include both the organisms listed above, but also enteric gram-negative rods such as Klebsiella and E. coli. First-line options would include amoxicillin clavulanate, marketed in the US under the brand name Augmentin, and ceftriaxone. Second-line agents would be the so-called respiratory fluoroquinolones, moxifloxacin and levofloxacin. Lastly, if the exacerbation is severe, or the patient has risk factors for Pseudomonas, one would want to cover for that organism as well. Risk factors for Pseudomonas include hospitalization within the past 90 days, and FEV1 under 50% predicted, previous isolation of Pseudomonas from a sputum culture, or 4 or more courses of antibiotics within the past year. Antibiotic options in this case include piperacillin tazobactam, marketed as Zosyn, as well as levofloxacin and cefepime. There's one additional point to make about antibiotic selection. As the subtitle of this chart states, antibiotic selection should be tailored based upon your local population and antibiotic resistance patterns. Returning to our main chart, for how long should antibiotics be prescribed? A meta-analysis has compared 5 days to 7 or more days of antibiotics and found no difference in treatment success, but that a 5-day course was associated with fewer antibiotic side effects. Therefore, a 5-day course is recommended. Keep in mind that this duration is for the use of antibiotics in a COPD exacerbation without obvious pneumonia. If the patient has a clinically apparent pneumonia, the duration of antibiotics should be based upon whatever you would do for that disease, which is typically a bit longer. As with asthma, the last option in the management of COPD is vent support, though unlike asthma, BiPAP has a more clearly established benefit. Despite that benefit, it's still probably slightly underutilized, so I'll spend just one more minute on it. There's a great review and meta-analysis from CHEST in 2008, which found that the use of BiPAP both reduced the risk of intubation and reduced the risk of in-hospital mortality. Most interestingly, the benefit was largely dependent upon the arterial pH at presentation. In this rather busy but fascinating chart, the average initial pH for each arm of each study was plotted against the risk of intubation. What it demonstrates is that when the patient's initial pH was normal, there was no benefit to BiPAP, here referred to as NIPPV for non-invasive positive pressure ventilation, but that the benefit increased the lower the pH was. This is a good reason to consider an ABG in patients presenting with COPD exacerbations, to help determine which patients should be tried on BiPAP. Okay, so that was a pretty thorough summary of the treatment of asthma and COPD exacerbations. I'm going to end with 2 additional brief issues, both concerning COPD. The first of these is oxygen therapy. It's frequently discussed and occasionally seen that the administration of excessive oxygen in patients with severe baseline COPD can worsen their hypercapnia. Why is this? Historically, the most commonly cited reason has been that patients with chronic respiratory acidosis adapt such that low pH or high PCO2 are no longer effective stimuli to breathe, and that ventilatory drive is dependent upon hypoxemia. When hypoxemia is overcome by the administration of supplemental oxygen, patients breathe less. Well, although this explanation seems to make perfect sense, when actually studied, it turns out to not be the major mechanism. Instead, the major mechanism appears to be that excessive supplemental oxygen overcomes the normal hypoxic vasoconstriction within the pulmonary vascular bed, which then worsens VQ mismatch. For a patient with severe COPD, some parts of their lung may not ventilate very well. Poorly ventilated alveoli develop low oxygen levels, which lead to the vasoconstriction of adjacent blood vessels. This vasoconstriction diverts blood away and towards better ventilated regions. This helps to preserve normal ventilation-perfusion matching. When one supplies the patient with tons of extra oxygen, this oxygen can reach the poorly ventilated lung regions due to simple diffusion down the airways, which then reverses the adaptive vasoconstriction. The third mechanism by which oxygen can worsen hypercapnia in COPD patients is the Haldane effect. Remember that the Haldane effect is to carbon dioxide what the Bohr effect is to oxygen. Essentially, deoxygenation of blood increases the ability of hemoglobin to carry carbon dioxide. So by increasing the oxygenation of blood, hemoglobin's affinity for carbon dioxide becomes less. Due to all these mechanisms, patients with chronic hypoxemia should only use enough supplemental oxygen during exacerbations in order to maintain an O2 sat of about 88 to 92% and a PaO2 above 60. The last issue is the association between COPD exacerbations and pulmonary emboli. There are several reasons why such an association might exist. First, patients with severe COPD are relatively immobile, possibly increasing their risk of a concurrent simultaneous PE from that alone. COPD is also a pro-inflammatory state, which might increase thrombotic risk even in the absence of immobilization. PEs might be able to mimic a COPD exacerbation. And last, a PE might actually be able to trigger a COPD exacerbation. To see how big a problem this actually is, a 2009 meta-analysis of 5 studies examined the prevalence of PEs during acute exacerbations of spirometry-confirmed COPD. So these weren't patients with suspected COPD, but patients coming into ERs with diagnoses that had been previously established with PFTs. They found an overall prevalence of 20%. So among patients presenting to the ED with what appeared to be a COPD exacerbation, 20% of them had a PE. This was surprising to many doctors, and naturally they wanted to know if there was any way to discriminate between those COPD patients who had PEs from those who didn't, without needing to order CT angiograms on every single one. Such means of discrimination were examined in this meta-analysis and review. Among the 5 studies, one showed that the patients with a PE were more likely to complain of chest pain and less likely to complain of cough and sputum production. Unfortunately, the other studies showed no difference in symptoms. None of the studies showed differences in exam, EKG, or chest X-ray findings. One study found average initial PaCO2 was 5 mm lower than baseline in patients with PE, and one study found patients with PE were more likely to have a malignancy or prior episode of venous thromboembolism. Using that limited information, along with my personal experience and opinion, here's the algorithm that I use to determine which patients with COPD exacerbations should be evaluated for a PE. First, ask, does the patient have cancer or a prior DVT or PE? If yes to either, evaluate for PE. If no, look at the features of the presentation. Are they atypical? That is, were symptoms very abrupt? Is there no change in the patient's cough or sputum? Is the pCO2 reduced from baseline, which is highly unusual in pure COPD exacerbations? Or is pleuritic chest pain present? If any of these atypical features are present, evaluate for PE. If, on the other hand, the presentation is typical for COPD, that is, the onset of symptoms is over hours to days, cough and/or sputum is worse than normal, and the pCO2 is either increased or unchanged from baseline, then just treat for COPD. After 1 to 2 days, ask if the patient has improved. Since COPD exacerbations most commonly improve relatively rapidly with bronchodilators and steroids, if it does not, evaluate for PE, as well as reconsider other conditions such as a CHF exacerbation, infection, etc. If the patient has improved on standard COPD treatment, then just continue it. For this algorithm, the endpoint of, quote, evaluate for PE does not necessarily mean order a CT angiogram. If, despite the reason why you've reached this point, you feel that the patient is really low risk, or they have a low Wells score, then checking a D-dimer may be all that is necessary. Or there may be some situations such as poor renal function in which a VQ scan would be more appropriate. So that concludes this video on acute exacerbations, and also concludes this 4-video series on asthma and COPD. I hope you found this information to be helpful. If so, please remember to like it and share it with your colleagues and classmates. And don't forget to subscribe in order to see more med ed videos like these.